Hello everybody, this is Kate Wakelin here from Neuroendocrine Cancer Australia and welcome to Facebook Friday once again. I can't believe it's Friday already. Thank you to everybody who is joining us and also to those who are catching up with us after the fact. So this video is available afterward. Before we get going today, on the 12th of June 2020, I just wanted to acknowledge that I am beaming to you from Wurundjeri land, and that's the land of the Kulin Nation. I'm very grateful to live by the Yarra River, which is the Birrawong in language, and I pay respects to all elders past, present and emerging. So today we're so grateful and thrilled to have Associate Professor Ben Thomson join us. Associate Professor Ben Thomson will introduce himself. So I don't want to muck around. I want us to use our time as best we can and get onto the questions that lots of people from our group have sent to me via message and email and in the discussion on screen. So Ben, welcome to Facebook Friday. We're so grateful to you for making this time available with us today. Do you want to tell us a bit about yourself?
Sure. Thank you for the invitation to talk today. And as everyone knows, I've been actively involved in the treatment of neuroendocrine tumours for a while, so I'm really keen to be involved in whatever sessions I can be. So my name's Ben. I'm a hepatobiliary surgeon. I work at Royal Melbourne Hospital, where I'm now the head of surgery here, and I work at Peter MacCallum, where I'm the head of upper GI cancer. And so through working at Peter MacCallum Cancer Centre with fantastic medical oncology and nuclear medical physicians, I've got a great team there in its now recognised Centre of Excellence for the treatment of neuroendocrine tumours. So I work there along with a couple of other hepatobiliary surgeons and other surgeons, colorectal surgeons, upper GI surgeons, as part of the neuroendocrine tumour stream, essentially. So call me Ben. I'm just consulting at the moment from my rooms, which is just next door to the Royal Melbourne Hospital.
Fantastic. Well, thank you so much, Ben. So we did have some really good questions that were given to us, and I've given to these to Ben ahead of time so that he had a chance to see what was on people's minds. Ben, I'd like to start with, and I'm probably going to go in the order that they were given to me in. The first question that I was given, and I think this is a really common one, I was so glad when I saw it in the discussion feed, which is, well, why some people are able to have operations to remove tumours and some aren't. So the background to this was that this person's been told that their tumours are inoperable, but some people seem to have the same diagnosis, and they can have surgery. So can you tell us about that?
Sure. So I treat a number of different things. So maybe I'll just start off by talking about liver tumours and talking about colorectal cancer. So it's a far more common problem that I treat is colon cancer that's metastasized to the liver. And the thing about colon cancer is it often behaves in it's common and it behaves in a very similar way. So each cancer, although genetically often very different, the same sorts of rules apply for each of those cancers. So we have structured ways of managing them and different people agreeing on the management plan because they behave in a very similar way. So the problem with neuroendocrine tumours is that they are rare, although because they're so slow growing, the prevalence in our community is still high, but they're still rare tumours and they all behave very, very differently. And they behave differently compared to their site of origin and also to other factors, which I'm sure many of you heard about, the differentiation of them, the grading of them. And every tumour, even if it looks the same in terms of where it's come from and its grade and other things like that, can behave really differently. And so a rare group of patients with tumours that can behave in lots of different ways, where it's hard to actually create a set of rules that covers all patients. So as part of the fact that it's rare, the other issue is that when we like to try to rationalise a treatment for any patient with cancer, whether that might be surgery or chemotherapy or radiation, we like to give our standard treatment to one group of patients and then create a second group of patients to give a new or novel therapy to, so that we can compare the two groups to see whether or not there's any benefit. The problem in neuroendocrine tumours is they're rare, so no centre really has is able to put together the numbers of patients that you would need to make some of these decisions, what we call a randomized study. And also because they behave all differently, it's very difficult to match those two groups. So particularly in surgery, there is not a lot of evidence to support many of the things we do. We have, people who've had an experience and they've said, I've managed the tumours this way and I've done this and I feel that these patients do better. But it's actually extremely difficult to scientifically prove that those patients are doing better with those treatments. So they're a real complex group of patients. The next thing is that there's sort of different philosophies for managing neuroendocrine tumours. So sadly, many of the patients that I see often have very advanced cancers. And so because they're advanced, our ability to surgically manage those patients is minimal. But there's a lot of neuroendocrine tumours that are just very sort of small things in a single place that are quite simple to manage surgically. So again, very different groups depending on how early they are in their disease or how late they are in their disease. So I actually personally believe that a few things about neuroendocrine tumours. So one is that the vast majority of them are often extremely slow growing. And therefore, in some parts, even without any treatment, they will live the rest of their life and actually not have any problems with their neuroendocrine tumour. And in the past, when we used to do postmortems on patients, we used to find the rate of us finding neuroendocrine tumours that are metastasised around the body was far, far higher than the rate that we actually made that diagnosis. But these people lived their life, their life ended from a different problem. And, they were found to have these metastatic neuroendocrine tumours that they'd never had any symptoms from. So it's a very, very different group of patients to patients with common cancers like lung cancer, breast cancer, colon cancer, where if they didn't have any treatment, they would be in a lot of problems within 6 to 12 months. So that's the first thing, is often and the majority are very slow growing. And so one of the commonest arguments I have with some of my surgical colleagues is around small neuroendocrine tumours. So in my experience and based on the European guidelines, well-differentiated tumours, particularly of the pancreas, that are smaller than 20 millimetres in size, my usual thing is just to watch those tumours and not to operate. And I've got many patients that I've been watching like that for 10 to 15 years with nothing changing. And so therefore they haven't had to have major surgery with a lot of consequences and risks associated with it. But other surgeons feel often that when something's small and easy, it's a much easier operation to do it, and they prefer to operate on those patients. It just really comes down to a matter of personal opinion without a great deal of evidence to back it up. So that's, a common area that I think there is some disagreement between different people. And then with the very big radical resections that we might do, very big liver resections or taking out tumours in the abdomen that have a lot of involvement of other organs around them. Again, there's a big difference in opinion about whether or not that even helps. And again, one of the other huge things that's changed is all of these new biological agents that have been coming on to the market, even things like, the evidence for somatostatin analogues, long-acting somatostatin analogues, has really been only coming out in the last 4 to 5 years about the fact that in many patients increases what we call their progression-free survival, so that the time before we start to see the tumours are growing. And so most of the studies that we base much of our surgery on are from before a time where we had good quality CT scans, MRI scans. It was only within the last 6 or 7 years that even in the United States, they had good quality PET scanning for neuroendocrine tumours. So much of the stuff that we've been basing what we do is based on very poor evidence and just experience.
So I think the thing that I'm picking up is that, and I think there is almost like a difference between what the patients that I talk to often think or the way they approach the idea of surgery. And what you're saying to me is that when maybe a layperson, a patient might think of an operation, they're thinking that that's going to take all of the tumour out of their body. Yeah. And I think from what you're telling me that's a bit of an old-fashioned way of looking at it, and it's not necessarily backed up by the evidence, but also that there's big problems that can happen with operations. That's right. There's quite a risk.
Yeah. So, I mean, one way, the simple way of deciding surgery is going to help is if you have a neuroendocrine tumour in a location and it has not spread anywhere else in the body, then if I remove that with an operation, you are cured. But the problem is you don't know if little tiny cells have travelled elsewhere in the body or not. And if they have, and I do this operation, it's got the main lump under control for a period of time, but these other cells will regrow at a later date and come back. So those patients are not cured. What we're starting to realise with many neuroendocrine tumours is that they are probably in 95% of patients with a tumour that requires surgery, 95% of them, they're probably already metastasised elsewhere in the body, but there's just no evidence of that. So pancreatic cancer, not neuroendocrine tumours, we know that it's extremely rare that we cure someone with pancreatic cancer because before the tumour is even visible, it's nearly already metastasised to other places in the body. We think neuroendocrine tumours are probably very similar. Once they reach a particular size and start to metastasize, it's probably a very wide thing, but we just can't see that. But the difference here is that it may be 20 to 25 years before those tumours decide to start growing and showing up. And so it's a very different process to pancreatic cancer, which is, things show up even with surgery within 12 months. Patients who have major resections for neuroendocrine tumours, things can still occur 15, 20, 25 years later. So therefore, it's sort of the philosophy of I can just have an operation and I'm cured. That may well be true for little tiny neuroendocrine tumours, but the reality is you might not even need an operation for those ones anyway.
So the decision making sounds really complicated to me.
Yeah, no, it can be. So certainly for the small ones, if we talk about pancreatic tumours, small pancreatic tumours, we normally watch them till they're about 2 centimetres in size, as long as they are behaving like a very slow growing neuroendocrine tumour. Larger tumours than that, if there's no evidence, or sometimes even in the presence of metastatic disease, if we can remove the tumour and remove the metastases, we will do that as long as the patient understands that the evidence for that is not strong. And as long as, in my opinion, the risks of that operation are not huge, so I want the operation to be an operation the patient's going to be able to cope with as low a risk as possible, because I know there's a very high chance that at some point in the future, other stuff will show up. So small bowel ones, though, just quickly, they're a bit more problematic. So even tiny little small bowel neuroendocrine tumours can cause a lot of symptoms and problems. So invariably, we would try always, if we just see local lymph nodes for those, we will often try and operate on them in a much smaller size.
So I want to come back to small bowel tumours, because that was one of the questions that was asked. But before I forget, because this wasn't on the list of questions, but I think it's something that comes up a lot in the phone calls I get from patients who call the Net Nurse line, and that is, if they've had a tumour taken out, like they've had a Whipple's procedure for a pancreatic tumour, or they've had another tumour that's been sort of found on a colonoscopy or a gastroscopy, or they've just managed to find it and they don't think, they can't see any spread. What's the monitoring? That sounds like that monitoring has to go on really for decades. Can you tell me about what that might look like?
So again, there's not strong evidence to tell us what to do. All right. And so, if it's a gastric carcinoid, a gastric net, those can often, just be screened by having a gastroscopy, because often you can just remove them just by burning them off. So that's a relatively simple way of doing that. Obviously, for a rectal net, again, that could be watched with colonoscopy. But for most of my patients, if the tumour's been removed, obviously in the first few years, I monitor things a bit more closely, and that's often alternating CT scanning at 6 months, and then 6 months later, a GAT8 PET CT, if it was a well-differentiated tumour that will show up on that. And I do them every 6 months, but I can tell you that, the majority of the time, 95% of the time, following patients for several years like that, nothing shows up. And then after a period of time, we move to yearly alternating examinations. In the past, we used the chromogranin A test sometimes as well, but the problem with that, if we've operated on someone is it really goes up and down for lots of different reasons. So just being on an anti-acid medication can do it. Your kidney's not working quite so well can do it. Lots of different things can make it go up and down. And so I haven't found that to be particularly useful. It's useful in monitoring patients who've got metastatic disease that's being treated in a different way, but not so much for surveillance after surgery. Another model could be just to do nothing and just to re-image people if they have symptoms. But because we're getting more and more ways of treating neuroendocrine tumours, we often feel that it probably would be better to try to treat them earlier if they were to occur rather than later. And if they're coming back early, you're not going to have any symptoms from that, so you need to rely on imaging for it. And the last thing I was going to say, sometimes for the liver, MRI is a better way, and obviously no radiation. MRI is a better way of looking at the liver, but it's not funded by the Australian government for that indication at the moment, so it can be quite expensive.
Well, that's really interesting, and perhaps something for our advocacy team to be looking at. So that's really useful. Thank you, Ben, for explaining. Let's come to the small bowel tumours, because that's something that we wanted to come back to. Can you tell us about how you make a decision about whether or not to take out a small bowel tumour if there are other metastases present? Along with that, there was a really interesting question about small bowel obstructions and surgery for obstructions in the small bowel. So while we're in that neck of the woods, maybe we could discuss that, if that's okay? Yeah,
no, that's fine. So look, small neuroendocrine tumours in the small bowel, we would normally remove them, because if we leave them there, we know that they're quite aggressive. They'll spread to the local lymph nodes and to the liver, and they can cause a lot of problems. So when we make that diagnosis, we would normally do what would be a relatively straightforward operation in most patients to remove what is most frequently the last little bit of the small bowel and part of the right side of the colon, as well as the lymph nodes. And that's kind of because in the past, when we let these patients go, they often ended up being really problematic and treatment was really difficult. Recurrent bowel obstructions and pain and flushing and these sorts of things. Sadly, I don't see those patients, because most of the time they're treated outside of Peter Mac and Royal Melbourne at other centres, because that's a very common operation that any general surgeon or colorectal surgeon would do frequently and often laparoscopically nowadays. And they're very good at what they do. So, the majority of those patients are treated before they even come to us. The next group of patients is those who have sort of obvious lymph node involvement. And so again, an operation in them is the right treatment. Sometimes a bit more complex. So something that we'd often get our colorectal surgeons to do, because they are more experienced with treating colorectal cancer and taking the lymph nodes as far along the sort of chain. So lymph nodes drain lymph, and if you imagine, it's a bit like a train line. So there's the tumour, and there's a train line leading from that, and it goes to a train station, which is a lymph node, and then it goes from there to the next lymph node and to the next lymph node. So usually they sort of spread along in a stepwise fashion. So for higher lymph node involvement, the colorectal surgeons are often involved in that to try to clear them. Then you get patients where it's spread beyond that, sort of up to the lymph nodes around the aorta and around the pancreas. And those sorts of lymph nodes, there's not a lot of evidence that radically chasing them is going to help. But in fact, there still may be evidence for resecting the primary and the local lymph nodes, because we think that if you leave them behind, they can cause a lot of problems. Again, this is all before the time of long-acting somatostatin analogues. So the numbers of patients where we used to operate when they had more extensive disease is much lower now, because often long-acting somatostatin analogues control their symptoms. Then there's a group of patients beyond that who get recurrent small bowel obstructions or symptoms like small bowel obstruction. And often that's because the tumour is blocking the bowel. But you can also often get very similar symptoms from the local lymph nodes. So what happens is that they get stimulated by food, they release a lot of hormones that interact with the blood supply locally, and they cause the bowel to not function properly and to not have a great blood supply, which causes a lot of pain. So it's actually hormonally related to the lymph nodes and what they're producing. So if you just remove, if you imagine the bowel is like a hose pipe and there's a blockage and you just remove that blockage, often that actually doesn't fix the symptoms. Sometimes you've still got to do a more radical operation to remove the lymph nodes that are secreting the hormones that are affecting the blood vessels going to and from that part of the bowel, which are part of the problem. And that's a much bigger operation with more risk, and an operation really that should be done only by people who are used to operating on these patients, because it's not like normal run-of-the-mill bowel resection.
So this is perhaps a question to ask a nuclear medicine person rather than a surgeon, but how would, and this is actually goes back to a question I wanted to chase up from when you were talking about gastric tumours and burning them off. How would you know if there were lymph nodes?
So thankfully, GAT8 PET-CT or gallium-68 or whatever, so that's a PET scan that's done using, pardon me, the somatostatin receptors that we see on most neuroendocrine tumours to light up where the cancer is. And so that is a very sensitive way now of identifying lymph nodes that are involved by this. It really, so when I was first back from, I used to be a liver transplant surgeon, and I, after doing my training in Australia, I trained in Scotland, and then I became a liver transplant surgeon in Edinburgh for a while. And when I came back, that sort of PET scanning was only just becoming available. And so worldwide, we based all of our decisions on pretty poor ways of staging patients just with CT, which wasn't very good. But that made an enormous difference to what we were seeing. And so it helped us to, identify some patients who we thought had who had things in the bone and that were widespread. Pardon me. And so, that's a really key part now of us trying to select the right patients for an operation and identifying things like the extent of the lymph node spread.
So just a quick question about that, Ben. If someone knows they've got a neuroendocrine tumour present and they're going to have an operation, should they have a PET scan before the operation?
Yes. So in my opinion, they should definitely. They're probably, I think most surgeons in Australia now would know that was a critical part of the staging. It's possible that there are a few people that don't, but I think nearly every surgeon that would do this sort of work would know about that. The other great change is that they're now a funded indication for a PET scan. So evaluation of a neuroendocrine tumour is now a funded reason. So part of the problem in the past was that they might cost a patient $800 to get that done. And now we can get them done for free as a Medicare funded indication. And so that actually makes, our ability. So sometimes we made decisions not to do it based on the fact that the patient may not be able to afford it, because $800 is a lot of money. But now that's free, essentially. That makes it much easier to get it done.
And I'm sorry, because I'm thinking of more questions than the patients, but I've got you as a captive audience. For someone with a small appendix tumour, and actually I do get a lot of phone calls from people with appendix tumours, and I know that they are seen quite differently. If the tumour is, like, at what point would you want to be doing a post-op PET scan on someone who's been...
So obviously the majority that I see have already had their appendix taken out, and then they come to me because it's been done. So I think it's such an excellent investigation that in all of them I do that scan, all right? Because it also gives an element of reassurance to the patient as well. I know they'll often sit there thinking, well, I haven't had one, so how can you be sure? So I would do that as first line for anybody that I see, all right? But the reality is that it's very rare that it actually shows much there. There's a whole lot of things about an appendice or neuroendocrine tumour that can help us to predict the chance of them having further disease, or predict the chance of it coming back, related to the size of it and how the appendicectomy was performed, and the types of cells that we see in it and the grade and all of these sorts of things. But fundamentally, I get a lot of calls from around Australia as well about it, and often that's one of the key things that people want to know. Shouldn't I have a PET scan? And I think, there's no risk, really, very little risk in having a GAT8 PET-CT done, so I organise it in most patients, predominantly wanting to reassure them that everything's okay.
Thank you. That's a really helpful question to have answered, because it's one that comes across my desk quite frequently. I wanted to now have a talk about lutate therapy, or PRRT, knowing that it's not always lutate, but the peptide receptor radionuclide therapy. And if that, the question was, and I'm going to quote it because it's a greatly worded question, if lutate can shrink or lose some of the buggers, then am I a candidate for liver surgery? And there was also a similar question, which is, if I haven't had previous surgery and then I have PRRT, would that then make me a possible candidate for surgery?
So again, this is complex. So I'll start off by talking about not liver, but outside. So we published at Peter Mac about 5 years ago a group of patients where we decided that they were unresectable for whatever reason, and we gave them PRRT therapy. And in one of those 5 patients that we initially published, I went on to operate on them and to resect their tumour because the response was so great that the reason that they were unresectable changed and they became resectable. So we published on that, and more people are publishing on that now. So for some pancreatic tumours, it has enabled us to shrink the tumour to a point where we can now operate to remove the tumour. In liver tumours, it's a bit different, all right? So one of the first patients that I operated on when I came back from overseas in 2000, I think it must have been 2004 or 2005, was a young 17-year-old boy who had a football-sized neuroendocrine tumour in his liver. And he, in fact, was diagnosed. The doctors ignored, he had abdominal discomfort. The doctors didn't feel there was anything wrong. But I think if I recollect, I think his sister might have been a dietitian, and she got him seen by a massage therapist who felt a lump in the abdomen and made the diagnosis. So it's pretty amazing. When I operated on him and took out his right liver, we found multiple other small tumours throughout his liver. And so he was then subsequently treated with PRRT treatment. He was in VCE at the time. So I know that now, 16 years later, he's alive and well after he's had 3 treatments with PRRT. He still has tiny little tumours in his liver that you can see on a GAT8 PET-CT, but they have not changed in 16 years. He's married, working, had children, and so really the surgery just took out the largest piece of the equation, and the PRRT treatment fixed everything else. So in fact, if you had tumours that were not resectable and you had PRRT treatment, it doesn't necessarily follow that if you get a great response, removing some of those tumours is actually going to make you any better than PRRT already has. But we just don't know, all right, is the problem. So what we tend to do is if you have PRRT treatment, you have a great response, we tend to observe. And if you then develop one of those tumours growing again and not responding to other treatment, now what's happening is we're tending to operate on those more active tumours and we ignore the ones that are stable.
Thank you. Ben, I am aware of the time, and I told you that we'd finish at 1:30. I'm also aware that our live feed has dropped out.
Okay. No
continuing to record, it dropped out after about 30 seconds, and I didn't think that it was particularly helpful for me to mention that to you.
That's right. No problems at all.
Do you have, there's a couple of questions left that would
I'm happy. I've still got time if you want to go through them.
We've got a couple of minutes left.
Yeah.
Thank you so much.
No problem.
So one of the questions which I was interested in was why doctors seem to operate more in other countries than in Australia with
I saw that one. So again, I was fascinated. I went to a meeting in America, the American Hepatopancreatic-Biliary Association meeting, and we had one session just on neuroendocrine tumours, and they put up pictures of different tumours, and everyone had to click a button, would they operate or not, based on that. And I knew what Australian surgeons were doing, but I was, and so one of the things was for small tumours who would operate, and it might be 50-50 in Australia, but in America, the majority of surgeons were still operating on small tumours, despite the really strong European evidence that you don't need to do that. So that was fascinating, but part of the problem is the evidence. And I think also surgeons don't cope well when there's a tumour that's very easily removable and someone watches it rather than taking it away. But it is something we're seeing increasingly in renal cancer. You know, we're observing small renal cancers without doing anything. And we're also looking at other ablative therapies for small tumours. And I think it's not inconceivable in the next few years that small pancreatic tumours, neuroendocrine tumours, may actually be able to be ablated or burnt using techniques like microwave ablation through endoscopic ultrasound. So those patients may never need anything done. It may be possible just to do a local ablative therapy. Not
So
there yet, but we're almost there.
yeah, and that sounds really exciting. So just to I guess recap that answer, then it sounds like the evidence is still emerging that it could be a bit of a cultural tradition within the
Yeah.
country.
Well, you got to remember, surgeons are often love to be superstars, and a way of being a superstar is to do the biggest operation that nobody else does, and to get someone through that operation. And so, unfortunately, often people see, some really radical resections as a huge sort of, I can do this and I can get my patient through. And I think, I understand why people sort of think that, but I think that many of our newer therapies that are coming out are offering as good treatment without patients having to undergo the consequences of really large resections and the complications and long-term problems that can come from that.
Okay, thank you. I think that's a really great answer, and I was really interested to hear that too.
Yeah.
The last question I have for you, I had to get out my Dr. Google, which I'm not supposed to do, but I do, and I know everybody else does too. But I thought, fantastic that you're going to be joining me, because now I need to ask you, would you ever inject EV46 directly into the tumor?
So I've not seen that as a treatment for any of the tumours that I commonly deal with, but the commonest liver cancer, primary liver cancer, is called hepatocellular carcinoma. It's the 4th commonest cancer in the world. And there is a study at the moment where we have been injecting hepatocellular carcinomas with different agents to try to incite an immunological response by the body to get rid of that tumour. We have not used that in neuroendocrine tumours. We have used ablative therapy, so therapies where we put something into the tumour and we burn it. We have used that are injected into the liver, like transarterial chemoembolization and surspheres or radiotherapy beads into the liver to treat tumours. But often what we think is, if you have liver metastases from neuroendocrine tumours, we think nearly always the liver is quite extensively involved. You just can't see it. And so by doing these types of ablative treatments, you're really just often treating the tip of the iceberg and not really what's lying underneath. But the way of the future will be identifying a way to switch the body to start identifying these cells and killing them. So these types of injections into tumours of different agents to incite an immune response may well be the answer, but there's very little that I have seen at the moment for neuroendocrine tumours that this is effective.
I think that reminds me of the study that's been done in Adelaide with Rose Bengal, and perhaps we'll put a link to Professor Tim Price's presentation from last year on that, which is I guess a similar kind of technique, but some interesting, and it's early days with lots of this stuff, isn't it, that the evidence is emerging.
Yeah. If I had to choose a tumour to get of all the cancers that I treat, I would choose a neuroendocrine tumour, purely because of the fact that they are so indolent and slow growing in the majority of people. And there are some good effective treatments for it. Although many of my patients live with the unhappiness of them having a cancer that can't be cured, it is a far better cancer to have than virtually all of the other cancers that I treat.
Wow. Well, I think that's a really encouraging note to finish our conversation on today. So thank you so much, Ben.
No
I really appreciate your time, and I will hop to and get this video ready to pop up into our Facebook group today.
Thank you for the invitation.
So thank you so much to Associate Professor Ben Thomson. I know he wanted us to call us Ben, but old habits die hard, and I was a nurse who grew up at the foot of beds, bowing and scraping to people like Ben. So yeah, look, it's lovely to have experts like Ben able to join our group. I'm not going to hang around very long today, except just to say there's been some lovely conversations in the Facebook group. I love it when people come in and share, the positive stuff, the good news, things that are happening to them, as well as being feeling free to hop in and talk about what's causing them to struggle, what's really worrying them. And I think really special that we can have both things simultaneously in our group. So I'm loving seeing that. If you're watching this, one question that did come up over the last 24 hours that I'd love to see some conversations, some answers to this person, was about a decision about whether or not to have PRRT. So if you hop into the Facebook group and have a look at those conversations, I just think that if you've had PRRT, this person might really benefit from hearing what your experience was. And I think, you know, what's and all is fine. Like, this person really wants to make an informed decision, but wants to hear about people's experiences. So just to flag that. The other thing I just wanted to quickly plug was the online support group for next week. So for those of you who have clicked that you're going, it's listed as an event in our Facebook private discussion group. If you clicked going, I'll be sending you a message next Tuesday during the day with the link to Zoom. So for those of you who haven't used Zoom before, it's really easy. Like, a lot of people, a lot of really quite, my parents have mastered Zoom, so I think anyone can. It's just, you do need to download an app onto your phone or your computer before you beam into that group. So it's worthwhile if you are planning to come along to that group, just to get the app for Zoom. You don't need a Zoom account. I'll send you a link, and when you click on that link, it should just, by the magic of the internet fairies, take you into that group. So I'm looking forward to seeing lots of people then. It's next Tuesday evening, and yeah, the details are in the Facebook event. And just the other thing is that we've got lots of our groups that are normally face-to-face and meeting via Zoom over the next couple of weeks. We've had a few already, so that's been lovely to see some familiar and friendly faces and hear about what's happening with people around the country. So I'm going to finish up there. Thank you so much, everyone, for joining us. Yeah, I look forward to talking with you next Facebook Friday. Take care, everyone.